Good afternoon, everybody. Thanks for being here. I'm John Hale. I'm co-owner of the Hale Group, a Ankeny-based advocacy and communications firm that focuses on aging Iowans, Iowans with disabilities, and the caregivers who support them. It's my privilege to moderate today's session on rethinking long-term care facilities, a session that is described by the Gazette this way. The pandemic has encouraged a fresh look at structure and service strategy within the long-term care facilities. How can this industry expand and strengthen their scope to ensure the needs of residents and staff far exceed the status quo? Before getting into the meat of the topic, I want to take this opportunity to thank the sponsor for this session, the University of Iowa Healthcare, and pause for a brief message from them.
Hello, I'm Suresh Gunasekaran, CEO of the University of Iowa Hospitals and Clinics. We are delighted to be part of the Iowa Ideas Conference. Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. Challenges in recent years have accelerated how we think about and deliver healthcare. For example, we have seen a move towards telehealth, but we need to be careful in how we analyze that trend as UI Healthcare performs tertiary care, which is still largely inpatient. So we need to think long and hard about what these trends of healthcare mean. It has also highlighted serious gaps some Iowans face in receiving adequate healthcare services. As an industry, we are constantly innovating how we perform healthcare with the use of new procedures, innovative technologies, and new ideas. Let us start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
Okay, let's get into this. Today's session focuses on nursing homes in Iowa. There are over 430 of them. About half are for-profit facilities and the other half are not-for-profit. They have been in the news a great deal over the past 18 months in Iowa and across the nation. COVID-19 has been one of the variables that's drawn the attention of the media and policymakers. But there have also been numerous news stories and opinion pieces about the quality of care both pre-COVID and post-COVID, and suggestions that it's time to fundamentally rethink what the nursing homes of the future can and should be. To air all this out, we have an exceptional group of panelists who bring diverse experiences and opinions to the subject. I'm now going to turn to them to briefly tell you who they are and what they do, and we'll start with Shannon.
Good afternoon, everyone. My name is Shannon Strickler, and I'm the president and CEO of Leading Age Iowa, and we are an association that represents not-for-profit providers of aging services. And that would range from everything from home health, PACE, Meals on Wheels, all the way through continuing care retirement communities and nursing homes.
Thanks, Shannon. Next, Annie Pollock.
Hi, everyone. Thanks for being with us this afternoon. As John said, my name is Annie Pollock. I am the Executive Director of our Memory Care Center at Mercy Medical Center in Cedar Rapids, Iowa. Within that role, I'm really spearheading our aging and dementia transformation throughout our healthcare system. In particular, working on Hallmar Village, which is a partnership with Presbyterian Homes and Services. We're building new, I see some head nods, in Cedar Rapids, Iowa, opening spring of 2023 to have a different look, a fresher look at the full continuum of care there. In addition, oversee the memory clinic and work on building our innovation center for aging and dementia.
Thanks, Annie. Brent.
Hi, everyone. My name is Brent Willett. I'm the president and CEO of the Iowa Healthcare Association. We are a long-term care trade association that represents for-profit and nonprofit nursing homes, assisted living communities, home health agencies, medical directors, and hospice agencies in all 99 counties and about 230 cities and towns.
Great. Anthony.
Anthony Carroll. I'm the Associate State Director for Advocacy for AARP Iowa, working on state, federal policy issues, local as well, a number of issues. I've done so for 16 years, and certainly long-term care and long-term services supports, we describe it as, is a big part of that. Thank you, Cedar Rapids Gazette, for hosting, and thank you for all the fellow panelists for joining this discussion.
Thanks, Anthony. And last but not least, straight from the cross-country meet in somewhere in eastern Iowa, Dr. Clete Younger.
Yep, coming today from Cedar Falls. I'm Dr. Clete Younger. I'm a family physician for UnityPoint Health in Cedar Rapids. I serve as a family physician in an outpatient clinic. I serve as a medical director for 7 different nursing homes and work with a post-acute team. And I also serve as the hospice medical director for UnityPoint Cedar Rapids.
Great. Thanks, everybody. Let's start with a quick question, kind of a scan of the environment from each of you. The question is this: what's the current level of nursing home care quality in Iowa? Are residents being consistently well served? And do we have any data that gives us that answer? Let's start with Shannon.
Well, I think there's a lot of data out there. It just depends on what exactly you're looking for and how you want to measure that care. I think probably the biggest concern that everyone has related to care today would circle back to staffing and the ability to adequately staff and find people who are competent and want to work with older adults. And if we look at Iowa's workforce data right now, the picture's pretty bleak in a lot of categories. But if we look at nursing, for instance, we have 5,978 openings for nurses in the state of Iowa. In October, this is all workforce development data, but in October, they posted that there were 6,362 job openings with a potential of 226 candidates for nurses. So that's a less than a half a person. I mean, it's just crazy how many job openings we have in terms of supply and demand. So I would say that's probably the biggest concern we all have for quality long-term is who's going to care for everyone who needs the care.
Thanks, Shannon. Appreciate that answer. And we'll be talking a lot today about staffing and workforce challenges. Doctor, let's go to you. What do you see as the care quality and resident satisfaction out there in the facilities that you're part of?
So I think the quality of the way we provide care is significantly different. I think that we're using medications to help for dementia less, which means we're doing more behavioral interventions. We're doing a better job of appropriately diagnosing infections and treating those appropriately. And I think that we're training our staff to try to make interventions to try to improve quality of life without resorting to things like restraints or sedative medications and things like that. So there's been a big focus on that. In all the quality meetings that I attend, which are 7 every 2 months, everybody knows what the quality metrics are. Every nurse and NA in the facility is privy to that information, and their administrators are sharing that with them. So I think there's an understanding that you have to provide high quality care in order to provide the right care for the residents that are there. I think the thing that's unfortunate is I think the quality of life has changed significantly in the last 18 months with the pandemic. The effects of shutdowns, lack of visitation, and lack of communal activities has had a significant impact on the quality of life, just because the social aspects of being a human being have been impacted by that. But I do believe that the quality of the nursing care provided continues to get better each year because we have better data, and that data gets disseminated to the facilities and the staff so they're aware how they're participating so they can improve.
Thanks for that answer. I think it's really important to make that distinction between quality of care on the one hand, quality resident life on the other. We've all seen the impacts of that over the past 18 months. Annie, let's go to you.
Sure. I think adding to that conversation, beyond the quality is the social isolation, depression, quality of life you alluded to there a little bit, John. So I think beyond the minimum standards or the quality metrics, falls, et cetera, that everyone tracks, how are these individuals living? how is their well-being? What brings them meaning and purpose every day? So just having that shift a little bit to think about things differently beyond, again, these are quality metrics that we should be achieving in all categories. But how do we look at those individuals as people and figure out how can we make their day better and how can we improve their quality of life?
Great observation. We're talking about real lives here, and the extent to which people are satisfied with the life they have. And sometimes that doesn't necessarily show up in data, but really an important point. Anthony.
Yeah, well, I actually, again, a lot of the main points that have been covered by others. So, I mean, how do you measure quality? I mean, certainly you can look at citations and Department of Inspections and Appeals, number of citations issued, but does that really get to the issue of where are we in quality? And I think there's also, like some of these things, there's the pre-pandemic numbers, and then what does it look like with the pandemic, not just on the realities that's going on within long-term care facilities, but the ability of not just our inspectors, but our ombudsman to get in and not just correct them, or as an ombudsman office to help avoid some of those bigger issues. So citations is one number. I certainly think, I think I'd be remiss if I didn't say it's not so much even an indicator of quality control, but just the loss of life and the disproportionate impact of death in nursing homes and long-term care setting that I think everyone on this call agrees is tragic. Over 2,300 Iowans. So those are all people with names and people that lovingly try to care with them, wherever they were. So, but certainly I think the one thing you can look at in terms of measurable of area that is foreboding, and Shannon touched on this, and again, we all agree, is staffing. Today, actually, we just unveiled our monthly dashboard related to COVID in Iowa nursing homes. And it's a trend that has existed prior to pandemic related to our staffing crisis and shortage. But as of September in Iowa, over 51% of Iowa's nursing homes are reporting staffing shortages. So again, a majority of Iowa's nursing homes are reporting staffing shortages. These are numbers we haven't seen since last year. So it's certainly something that has been problematic. Certainly even higher right now. And that is, if you will, kind of, if this is about looking ahead, certainly I think something that everyone on this panel would agree, we need to do a better job of managing and addressing this.
Thanks, Anthony. And Brent, to you.
Yeah, Anthony makes some good points. He mentioned, pre-pandemic and if we may post-pandemic numbers. Something that we do have new and fresh in terms of reliable data is the CMS 5-star rating system. Is the system under which every nursing home in the country is rated. Those ratings have been unfrozen recently, and we have new data. The good news that we're seeing with those numbers is that Iowa continues to outpace its peers across the country with more 5-star and more 4-star rated facilities than both the national average and every other Midwest state. And so the challenges that we need to talk about today, notwithstanding, I think that where we can credit for some of those outcomes is the heroic efforts that continue to be undertaken by healthcare workers who still are there. And Shannon pointed to this. The numbers are incredibly stark. 9 weeks ago, we had 36,000 people working in long-term care in Iowa, full-time in Iowa. 9 weeks later, we have 31,000 people. And so we have seen an absolute, we have across the country, we have the same number of people working in nursing homes as we had in 1995. And so I know that we're going to talk a lot about this, John, so I won't belabor that point. But, I think as we talk about the future for long-term care and reimagining that, we are going to have to face the fact that we're not going to dig out of this workforce hole anytime soon. And we're going to have to think more closely about how we utilize our medical, both direct care and support staff in facilities.
Great point, Brent. And we'll definitely delve into this whole workforce issue in much more depth here in just a minute. A couple of questions. First, I'm wondering if the rethinking of nursing homes, the reimagining of how we serve people as they age or a person who becomes disabled, does that include the need to rethink how many facilities we need and how many people are being helped in their own homes, in a home and community-based setting versus a facility? And how do we know what people want? Are we responding to what they want, or are we giving them what we've always had? And I'm wondering, I know, Anthony, AARP's got some current or some fairly recent data on this. What does your data tell us?
Yeah, well, we have a number, first of all, data in terms of what's going on with our balance of taxpayer funding if it goes to long-term institutional settings versus home community settings. And then, and that is actually, now that's a little bit older in terms of the data. I'll come back to kind of where the realities of where Iowans are and where their expectations are. But for instance, our most recent, we do long-term care scorecards for all states broadly. This was pre-pandemic, but that showed that when you look at where we spend our taxpayer dollars, whether it be Medicare or Medicaid in Iowa, only about 26.6% of Iowa's taxpayer dollars go to home and community-based side of care. And by inverse, about 74% goes to institutional settings. So, and I think, so that puts us actually in the country relatively low, 39th in terms of it's on the lower side of it. But really within Iowa, I think what's more troubling is we moved in the wrong direction. We were at 30% at HCBS. So we've been trending the wrong way on that. And then if you throw out nursing home residents with low care needs, the percentage of them, we're 45th in the country with 15.9% of Iowans in nursing homes having low care needs, maybe perhaps better serve their homes. But the most recent data we have is actually just from July, survey of Iowans 50 plus. There's really interesting questions we asked. The question I think everyone on this panel will not be surprised if you or loved one needed long-term care, how important would it be to have services that would help you or loved one stay at home as long as possible? 86% of Iowans across the political spectrum, 86.4, think it's very important to have that be available. What's telling to me and really interesting is even higher number of a question that poses, do you support or oppose Iowa providing more home care instead of nursing home care? And again, this is July 2021 data, 91.4% of Iowans do support putting more of that investment into home care versus nursing home care. So I think there's data that supports where Iowans' expectations are, and frankly, almost surprising, even higher numbers when you do that contrast of home care versus nursing home care. So we have a ways to go on that. And I would also say as a positive, though, I do know actually both associations can point to that as something that I know as associations are trying to trend in terms of offering more services in homes communities. So, I mean, I'm optimistic that we're making progress, but we have a ways to go.
Thanks for that data, Anthony. I think it's really telling in terms of the desire of Iowans to kind of rebalance the system and to the extent possible, deliver more services where they are in their homes, in their communities, rather than needing to relocate to a facility. Shannon, I know you serve the spectrum of folks in a variety of settings. What does your data tell you, or just what are you hearing from your clients and customers?
Well, I think, there is a time and a place for the entire spectrum, right? There's always going to be a role for skilled nursing, for rehabilitative care, for long-term care in some settings. That's always going to be part of that continuum. But there's a lot of other services that can be done in different environments, consistent with, the needs and preferences of those older adults. This is where things start getting tricky, because then you have to start factoring in things again, like that workforce. It's a lot more efficient to care for people in one setting than to factor in travel time of going from house to house to house. And then also financing and how we pay for things. And unfortunately, a lot of care and the setting for that care is driven based on who the payer is. And until we get to a point where where it's not essentially private pay versus Medicaid, where people have almost essentially impoverished themselves to rely on that safety net program, I think it's going to be hard to see that full spectrum of care really grow as we'd all like to see it.
Shannon, I'd like to circle back to this, how we pay for services here a little bit later. Before getting there, does anybody else have thoughts on this particular topic and the whole rebalancing idea? How much of it needs to be done and why?
Yeah,
I have a couple of comments.
That's for Brent.
Go ahead.
well, I defer to Dr. Younger, certainly. I would just say that, pointing to Anthony's figure, the 90-10 figure, my question would be, who's the 10%? Of course, we all want to and prefer to stay in a home setting. Unfortunately, from a policymaking standpoint, we have to make difficult decisions because we have limited resources, to Shannon's point. I think that as we look at acuity levels in nursing facilities across the state, they continue to increase, which means that people are entering nursing facilities later in life and with more complex comorbidities, which is really what we want to see. But it does require a comprehensive solution. Unfortunately, it's not as simple as saying everybody should be cared for at home. We represent home care in our association as well, and so we want people to be cared for at home if they can be safely, and particularly if they're on Medicaid, if the system can support that. But it is a complex issue. It's I think about that 90-10 percentage, and it's kind of like Congress's approval rating. It's like, who's the 7% that approve of Congress right now? So I think it's a fair point, but it might oversimplify the challenge.
John, I know Dr. Younger had a point. I did want to follow, but go ahead. I think it was Dr. Younger want to make a point. So,
Did we lose him?
uh-oh. Well, while he comes back,
Annie
I'll
wanted
just
to make a
quickly-
point.
I'll tell you what, Anthony, before we get to you, let's go to Annie.
Yeah, go ahead.
What are your thoughts?
Sure. So I think 2 points to add to this. So one, Brent, yes, I like your question on the 90-10, but I think still for some folks, we see that when they enter in, just how much better they can actually be sometimes. So maybe they are totally isolated at home and don't have that socialization, again, back to living. So I do think, we see that, wow, so-and-so's actually improving after they moved in. So smaller percentage, but I think there's still a need there. I think just hearing the other panelists here has really had me think about, so if you think about, right, a more health system standpoint, Mayo Clinic, University of Michigan, Brigham and Women's, hospital at home. Best Buy just acquired a whole business, hospital at home. So it'll just be interesting to see in that industry how more people shift, right? I work no one really wants to come to the hospital unless you're having elective surgery or a baby, per se. So how do we care for people, hospital and home? Does that inertia work more? Is there more collaboration or brainstorming potentials too with the nursing home industry to think in that as well? I don't know, but it'll just be interesting as that continues to pivot here every day.
Thanks, Annie. Let's go to you, Doctor. I think we lost you there for a minute, but I think you wanted to jump into the conversation.
So I want to bring a thought experiment into this, and 2 thoughts for people. One, if you had to choose between living longer or living with more function for a shorter period of time, which would you prefer? And then I want to talk about what the realities of healthcare are. So we have gotten really good at screening and treating cancer. We've gotten really good with medications and interventions to treat heart disease. Unfortunately, if you get better at preventing strokes and heart attacks and preventing advanced cancers, and if people live longer with those conditions, you're still going to die of something else. And unfortunately, what we've created is we've got so good at treating cancer and heart disease that now people live longer, but then they die of dementia and Parkinson's disease. So you have to acknowledge that part of our advancements with cardiovascular care and cancer screening and treatment has led to an increased number of patients living their lives with dementia and other debilitating illnesses at the end of life. People don't like to lose function. It's very frustrating to watch it. It's very frustrating to be the person that's losing function. So one of the things I get concerned about when I think about, facility care versus home care, should we be looking at home care as a compromise? So unfortunately, longer life comes with the compromise of more need for support. And are we in medicine actually doing things to people to keep them alive longer, which may then have side effects and interventions that lead to increasing debility, where they then have to live in a nursing home for the last 6 months of their life because they lived 6 months longer because of a medical intervention or because of the side effect of an intervention. So when I talk to patients about as they approach, the later years in life, we really have a frank discussion about, we could do this intervention. It may make you live longer, but it may cause debility, or you may live longer at the part of your life that you may not desire. And I don't think that we do as good a job of talking with our patients about those realities and really asking patients what they want. Do you want to live longer, but live the last part of your life with less function? Or would you rather live shorter, but maintain more function right until the end? It's an interesting thought experiment and something we need to think about as we make decisions about how we treat our patients.
Well, amen to that. We could have several sessions just on what you talked about, Doctor, in terms of this longer, better conundrum. And that is such an important part of this, whether we're talking about interventions via surgical procedures or whether we're just talking about pharmaceuticals. We all have a healthcare industry that's allowing people to live longer, but is that the way they want to live? And I think you hit the nail on the head there. Before going on to the next question, Anthony, I just want to circle back to you. I think you had something you wanted to say.
Yeah, I think, point well taken, Brent, on the opinions is right, and preferences. I think probably that's the danger of using data. Which one do you focus on? I think perhaps the most important one was the first one I said, where our balance of spending is that only about a fourth of our dollars goes to institutional care, puts us relatively low. And to give you an indicator, the highest state performer is 70. It's the inverse. 3/4 of the dollars being spent on institutional care. So you can say that's an outlier, but I would say, can we at least get to where the state median is, which is 45%? So we're closer to half and half. So I think it's an objective measure that we have a ways to go in terms of our supply side of where we're providing care. And even if it's aspirational to get to that 90% who want to be there, it's not aspirational to say there's ways and policies we can implement, as other states have, to get closer to that 50-50 dynamic. Frankly, by the way, a state Iowa used to be, we were at 30%. So I think, but it's a good point. It's a good conversation. I appreciate your point.
Well, let's dig into this staffing issue, the workforce issue, the fundamental issue that impacts everything that we talk about, the number of people that we have working, the quality of the people that we have working, the consistency of the people that we have working, the amount of turnover that exists, the use of temporary staffing agencies because we have a lot of turnover. Let's just talk about this. My sense of what I've heard so far from you folks, my sense prior to this was that the situation was bad before COVID, and it's gotten a whole lot worse since, and it's gotten really bad just recently. Brent, you had referred to that in terms of some numbers that were pretty darn stark, to say the least. I know I had just one thing I wanted to bring up. This was just a cite as a reference. This was an article in McKnight's Senior Living, a publication that focuses on the long-term care system. This was from September 23rd of this year. And they reported that just 1% of nursing homes and 4% of assisted living communities who had participated in a recent survey reported being fully staffed. 1%. Now that is, that's concerning, if not scary, in terms of how that translates into the care that people are getting and the lives that they're needing. Anthony, you indicated that your surveys tell us that I think it was 51% of the facilities in Iowa reporting staffing changes. What's your take on all this? And not just what we have, but why is this happening? And I'm just going to look to, let's just start with you, Brent, get your take on this. What's going on here and why?
Well, how much time do you have? I know not very much.
Yeah. I
think that, look, the most immediate, obviously we have been in a workforce staffing crisis long before COVID. The pandemic has exacerbated it in extraordinary ways. So we have to deal with where we are in the present. the supply of workforce for long-term care facilities is shrinking. It's shrinking across most sectors of the economy, including healthcare, obviously. And the challenge that we have from a policy-making standpoint is making the case that we don't have a choice as a modern society, quite frankly, to not staff long-term care, because that means people die. It's a heroic effort to make sure that the ships at Los Angeles port are unpacked in time for Toys for Christmas, but it's really not where our focus should be from a national and state standpoint. And so what we know, what the data tells us, is that 70 to 75% of the spend, the expense side of a long-term care facility, is directly on labor. And that in Iowa, 55% of the revenue is derived from Medicaid. And when you include Medicare, that shoots up to about 70%. So essentially 70% of the revenue and 70% of the spend is directly controlled by what the reimbursement system gives us. And so what we need is more resources to be more competitive, to compete, quite frankly, with other parts of the economy. That's not a perfect solution, because we're not creating, in a state like Iowa, that's been the slowest growing population state in the country for almost 100 years, we're not creating enough human beings by any measure to address our statewide workforce crisis. But we need to make the case and be successful in ensuring that we need to be a prioritized workforce. In order to do that, we need to compete better on an economic scale than the rest of the sector. In order to do that, we have to have the resources to do that. Now, the state legislature has taken positive steps in recent years to increase particularly Medicaid rates in nursing facilities. We still have a long way to go. We're still facing about a $30 million shortfall for nursing facilities that will probably grow by the time we do these numbers again. But much more needs to be done in order to ensure that the sector can compete for the kind of labor that we need.
Well, this is and I can't even think of the right adjective to describe the situation we find ourselves in, but it's god awful, to say the least. Brent, you referred to making the case, and I'll just give you my own personal perspective. I mean, I've hung around the Iowa Capitol for the past 15 years, and we've been trying collectively, all of us have been making the case for resources to this industry, the home care industry, anywhere in the long-term services and supports industry, and the need for more of those resources to go to the frontline workers so that we do have more ability to recruit people and retain people. Where are we? Are legislators not listening? Do they not get it? What can we do to make a stronger case? For that, I'm just going to jump to Shannon and let everybody else jump in here to the extent they'd like.
Yeah, John, I think legislators recognize that it's a critical issue. Although I do think it's easy for some people to say, well, we have everyone has a workforce issue. You can't drive down the road and not see Help Wanted signs anywhere, right? But as Brent mentioned, it's a totally different story when people's lives are on the line. If you have to close a restaurant early and someone can't, go out for dinner, I'm not saying that's not inconvenient, but that is not a life and death situation. And so we really need to elevate healthcare. We need to elevate senior living, long-term care in particular, just because of the economics that we're dealing with. But I don't think it's as simple of, have we advocated that, senior living, long-term care is important enough? I mean, it is, we have a shortage of healthcare professionals. So it's not even, are we fighting, among a qualified pool and we just can't get enough applicants because the hospitals are getting them. I mean, we really have a massive shortage of nurses and physicians and LPNs and nursing assistants. The list goes on. So we need to figure out, we're going to have to find some short-term Band-Aids, and we're going to have to start, encouraging a lot of healthcare careers for, kindergartners. I mean, it's going to have to be short-term and long-term solutions.
Can we get to the point that where we can really make a fundamental dent in this? An example I went to the dentist the other day. I'm sitting there in the reception area talking to a guy, and he had just left his shift at Casey's. And he said he was making $19 an hour working at Casey's, and working at Casey's is great. We need Casey's and more power to them. But are we going to be able to get to the point of an industry that we can compete and get people to look at these direct care jobs, whether it be in home care, whether it be in facility care, as something, I want to do that. I can make a living at that, and I can make just as good of a living doing that as I could doing lots of other things. I mean, the gap here between what we're paying people in long-term care and what people are now getting in the marketplace out there in other parts of the economy is vast. Anthony, what's your take on all that?
Well, actually, again, I agree with the points that Shannon and Brent build off. I mean, there's really three legs to the stool. And this, by the way, connects back. We're talking about the nursing home side of things, but let's be clear. The issues, we maybe have more, we know we have more data related to nursing homes and assisted living, but these challenges we know exist certainly in the home side too. It's just easier to document and track in real time in nursing homes. So I think there's really three legs to the stool. And one is, as Shannon said, I really do echo the aspirational side. I think, again, having conversations like this on what we can do jointly to make this an aspirational destination, or at least part of the journey. I mean, how many people in your lives? I've had nieces who served in this capacity, and one who didn't because they wanted to do more sports therapy and physical therapy. Well, there's a huge demand to do physical therapy right now. Maybe you're going to get that career in some professional team, but there's a real need for that now, and maybe that's part of your career path. So I think there's a real urgency, and I know community colleges, we have a pretty active active set in Iowa who are trying to address this, but I think all of us really need to step up to make this more aspirational. And of course, connected to that is wages, right? Now, wages and compensation is key, and those are not one and the same. And this is maybe the undercurrent of all this is good data. The last wage survey that thankfully our Iowa workforce conducted on this, not just CNAs, but home health aides and personal care aides, looked at the median wage for direct care workers was $13.80. Now that's 2019 data, but that's not old data. I hope it's much higher. And I'm guessing my colleagues here will say wages and compensation is enough. So that first leg. I think the last thing is some positivity on this really dire area. I want to applaud our Department of Human Services for, first of all, applying for federal dollars to put in not just to more money for HEBS, but a big chunk of that change is building a public database that really a public database that looks at the availability of direct care workers, not just CNAs, but across the political spectrum. That's going to take time and dollars and input to build that. And you can not relitigate how much it's overdue. You can applaud that we're taking that step too. And I think, you talked about, and others can comment more directly on the role. I say temporary staffing agencies. Can we just drop the temporary? Because so much of how we filled the staffing gaps these last couple of years, not to mention several years. So I think it's awareness, certainly it's compensation, and then really good data and public data too. So I think this is one of the areas where I hope all of us are in this together on sharing ideas and how we elevate this profession and address this shortage.
Other thoughts from anybody before I go on to a related?
John, I would just add, Anthony mentioned, this is obviously a problem with a lot of inputs. And one of them is the extraordinary participation of staffing agencies in the sector right now. We're looking at data at our association. There was a $168 million increase in staffing agency utilization in the most recent quarter in the state. Now, why does that matter? That matters because, as I mentioned previously, 7 out of $10 that go in and go out of the long-term care facility are derived by the state and the federal budget. And so that should be a problem for policymakers because we're seeing an artificial inflation on top of extraordinary wage inflation as a result of the activities of staffing agencies bolstering the costs associated with staff. And we are not seeing, we're seeing costs increase. We're not seeing wages increase materially across the sector. And so we'll certainly be calling on the Iowa legislature to do something about this moving forward.
Brent, just to double check that figure, which was a shocker. Did you say that the temporary staffing agency cost went up $168 million?
We estimated it went up $168 million in the most recent quarter of the state. For context, in a non-pandemic year, the spend on wages for long-term care is right at about $1 billion. And so we're talking about $168 million increase in one tiny corner of the labor market. Less than 20% of the market is an agency. So it is a rapidly growing major problem in the economics of healthcare.
Thanks for sharing that.
So today I had an administrator come up to me and say, I lost one of my nurses' aides because this other facility is paying them $20 per hour. He's like, I can't afford that. How am I going to compete with these other facilities raising wages like that? So I think, we've identified a lot of the issues that are going on. What is going to happen, right? So we know staffing is not going to be solved quickly. So what do you see happening? So let's do that as a kind of an experiment real quick. Well, my experience with facilities is there's an economy of scale. So if you can keep every bed full, then your building is usually going to be more successful from a financial standpoint and be able to pay those higher wages. So what I think that's going to drive, I think the behavior we're going to see is that one, patients are going to move to facilities that have better staffing, and patients are going to move geographically to areas where there's buildings that are staffed. The buildings that are going to be able to compete in that environment are ones that are going to be able to keep their beds full and maintain that full census so that they can afford the staffing to be there. So I see the downfall of smaller facilities and geographic locations with less population. They're not going to be able to compete with places that can keep their buildings at 95 or 100% capacity, even with Medicaid patients, because those facilities are going to be able to attract staff and then pay them wages to be competitive. I think it's going to be challenging to get a lot more money out of the state government when there's so many different things to spend money on. So I think buildings themselves are going to figure out a solution. And I think that patients and families are going to see that, and they're going to use geographic movement to different facilities and locations. And they're going to see facilities that are better staffed that probably have a better census as the ones that are going to be successful. And I have personally seen several of the different companies that own multiple facilities putting lots of resources into census in their buildings. Even if it's Medicaid, because they are starting to see that having that census is the way that they're going to be competitive. So I really see in the next 5 years, smaller facilities and less staffed facilities are going to get pushed out. Buildings that are going to have a higher census and can attract patients to them are the ones that are going to be able to survive.
Well, I think that to add on to that point as a point of caution is that is a huge threat to receiving healthcare in rural Iowa. So as we talk about health equity, in a lot of areas it is, there's all sorts of diversity. And in Iowa, the rural urban issue is a critical issue. And I think your point it is a huge threat to rural areas and having families have to drive great distances to see their family members and to have them receive care.
Well, there's a variety of cross currents here, and Clete, you make a great point, but that's inconsistent with what we talked about earlier with what people really want, and that is they don't want to have to be in a facility. They want to have services close to home. Your point, though, is well taken, Clete, that it's, and others, that from an economy of scale, it's better to provide care to people in a centralized location where you got more staff serving more people versus traveling all over the hinterlands to get to people. Really interesting points, but I'm going to have to shift gears here because I want Annie to jump in to talk about the fascinating work that's going on in Cedar Rapids. That's focusing on, as I understand it, don't pretend to be an expert on it, but as I understand it, it's really one of those transformational projects, focusing on innovation, being willing to be a bit disruptive of the status quo in terms of how we think about and how we design long-term services and supports, exactly what I think the Gazette's interested in terms of this session. So Annie, if you would, help us understand what you folks are doing at Mercy and why you're doing it.
Sure. Thanks, John. What we're trying to do is, like you said, disrupt this industry, respecting all of the senior living communities that are out there, respecting the great care and work that's being done. But we really took a look as an organization and said, how can we do this differently? What do people want? Anthony, I love your data. Shannon, your data. But also just we took kind of a deeper dive in our own market here and quantitatively asked, but qualitatively as well. And what would you want? Why does it need to be any different if all of a sudden I come in the emergency room today and they tell me it's no longer safe to go home. I have to find a nursing home or a senior living community to live in because you're not safe at home anymore. So what we're trying to create is a place that's really a microcosm of your existing community that you live in. So somewhere that you can live with purpose, somewhere where your well-being is met, you've got that meaning and purpose every day, and really building on the community. So it's people helping people, not just the staff, which obviously is critically important that we've addressed in our conversation here today. But how can we do this differently? How can we build a community where people want to live, volunteer their time? We've seen models across the country, visited places internationally, and just seen how are different places doing this and trying to bring what makes most sense in our example here to Cedar Rapids, Iowa. So a unique partnership we have, again, with Presbyterian Homes and Services based out of Minnesota. They have several communities here in Iowa, but how do we stay on top of this? So we are building an innovation center for aging and dementia housed to be a part of that. So really this hub of research, training, education, where different ideas, maybe different staffing models that we've talked about, maybe different ways to care for folks. They're discovered, they're evaluated, they're piloted here. So bringing in kind of a think tank, maybe some of you will be a part of that, members of this panel, others, to come together to throw out these, what are these pain points, these tension points? How could we care for you better in your home? What would it take to move into a community like this? So really have that area to try out and pilot some things and say, wow, that worked. That didn't, or if this did work here in this community, could we pilot it somewhere else? Could we try this somewhere else? What are we not thinking? So kind of just being vulnerable in the space, trying to be creative, and really, we've talked about it before in conversations here, we're not in it alone. How can we elevate and bring all of us collectively to this, right? You want everyone to have the best care possible and quality of life wherever they're living. So how can we collaborate more versus, be as competitive as this industry can be? So just trying to do things a little bit different and experiment some and just pilot some different practices.
Well, fascinating stuff. We can all look at change, and we can look at evolutionary change, and then we can look at revolutionary change. And maybe we need a little bit of both here, but kudos to what you and Mercy are doing. I think it's just absolutely a perfect fit for what the Gazette is thinking about in terms of where we are versus where we would really like to be. And where we would like to be means, where would our customers like us to be? Where would the public like us to be? What would they like to have provided to them to make their lives better and to give them purpose? I mean, that's what the business is that we're all in. So that's wonderful. Comments on what's going on there. I know innovation is not just started with what Mercy's doing. I know innovation has always been part of the conversation. But any thoughts on what Annie has said before we move on to something else here? Okay. One thing I wanted to touch on before we leave this topic, and we've got about 12 minutes left. Shannon, you had mentioned earlier, and Brent, you've discussed it. I think everybody has touched on it one way or the other, and that is, what needs to fundamentally change? What do we need to do to change the way we pay for all of these services? We are, as I understand it, I think Brent, you use, I think a 70% figure. 70% of the funds used to provide these services come from a governmental payer. And I don't know whether that includes, the VA as well. I mean, we've got Medicare, we've got Medicaid, we've got the Veterans Administration as governmental funds. And the rest come from private pay. And we've, for years, if not decades, talked about, we got to have a different kind of a system here. Long-term care insurance, more personal responsibility for this rather than governmental responsibility. Shannon, you brought this up in a conversation we had the other day. Give us your insights into what has happened, what is happening, what needs to happen.
Yeah, so I think probably the first issue, and it kind of relates with what Dr. Younger talked about earlier, that as Americans, we don't really like to think about getting older. We don't like to maybe plan ahead and have tough conversations. And as such, we don't always understand the intricacies of how expensive things are or what we may need or how that gets paid for. And I think, there's a lot of Americans who think, oh, I have Medicare, that's going to take care of me. And unfortunately, a lot of families come to find out that those long-term care supports and services, the assistance with activities of daily living, like helping get dressed or helping with medication, that's not necessarily covered by Medicare. And so you are left with either paying for that independently by yourself or qualifying for Medicaid, which means that you have to hit certain low income thresholds. And that either is spending down all of your resources or using that as a safety net program because of need. So I think until we kind of fix that of haves and have-nots, or we have to completely spend down, we just don't really have a reliable income stream. And Medicaid, was not initially intended to support this system. It was intended to be a safety net, and that drives a lot of our problems. So whether that is a more universal system, whether that's in incentives for people to have long-term care insurance, we need to do something. We need to do something different, and we need to do it soon because we have a lot of people who are aging, and the system can't support all those needs through the Medicaid program today.
Shannon, if I could, just with a quick question, how much of this huge issue of payment and structures and sources, how much of that can be influenced at the state level versus how much of it is just a federal issue that's got to be dealt with federally?
Well, you have examples of states that are trying to be creative in this regard and offering certain benefit programs. Some states have pursued incentives for long-term care insurance where people could keep more of their assets. So if they demonstrated they had long-term care insurance, they could retain more of those assets and still qualify for Medicaid later on as kind of a win-win to states and those families. So I think there's opportunity at the state level. Of course, you certainly have a bigger bang for your buck in terms of a larger pool of people if you're doing it nationally. But I think we as a state could find some solutions, and that may actually be faster than the national level, just based on some of those comments about Congress earlier.
As I think about this, I'm thinking of, I think it's the state of Washington and some other states that have created their own payment structure to help fund some of these services.
Yeah, and I think that's modest, but it's a start, right? And we need to start experimenting. So,
other thoughts on this from anyone? Other perspectives?
I'll jump in. First of all, that Congress actually did try to do this as part of the Affordable Care Act. And so, but that's, neither here nor there. It's called the Class Act. But for those of you who want to go down a rabbit hole, take a look at that. So we did try to do this, but I'll go back. I shortly, just simply echoing Shannon's point, getting creative what we can do this. One more data point I'll say in Iowa, interesting fact, in terms of how we pay for nursing home care. Iowa is number one in other being a primary payer of nursing facility care, meaning not Medicaid, not Medicare. So that means Iowans are paying either their own assets or farmland or long-term care service. We have a relatively high number of people that private pay is how they pay. That's an important point. So now how we balance those dollars, I'm not going to revisit that topic. I do want to bring up something that I think is a really key in terms of who pays for this. Not just for nursing home care, since this is rethinking and reimagining. It's not a new thought, but it is a new emerging reality, and that's family caregivers. They provide the overwhelming majority of long-term services supports. Now, that's something they've been doing. I see Annie nod her head. I know Mercy's been ahead of this with their family care center. Naming and framing is something I think we've really put more words and efforts into how we can better support family caregivers. And I think when you look at the future, whether it be Dr. Younger's point, of what are long-term care systems like, or the present. The present reality is family caregivers are holding on even more so in terms of their loved ones, whether it be not returning to a home, a nursing home, or putting them back in there. Family caregivers provide a majority of it. So getting creative in terms of paying for it, supporting those realities. I mean, one of our survey this summer found that the average expense of Iowans who provide this care is at about $3,000. That takes the majority expenses. That's a lot of money for a family caregiver to provide that. So we think tax credits for family caregivers is a key way to financially support the financial burden that family caregiving is. And that's the finance side. And that's before I don't want to take up monopolize the time, but the rethinking, the reimagining is happening in the housing side, if you will, family caregivers, bringing not just someone into their home, moving closer to where their loved one is or have their loved one move closer to them, or setting up accessory dwelling units, the so-called Fonzie houses, where people, a family caregiver can be closer to their parent or vice versa. And the mutual benefits. Look, I live in Des Moines, but my parents are 82 and 84 and live in McGregor. That's rural as you can get. We grew up on a farm. And you see the mutual beneficiary of not just having my brother and sister-in-law care for them, but my parents being able to help provide grandparent care. That is typical, not atypical. So it's not all negative, but I think just acknowledging that the majority care, even as I talk about rebalancing, is already being provided by family caregiver. And I think there's going to be even much like you see in childcare, an increased expectation. I think everyone is, Brent and others have talked to this about the technological side, Annie, the technological aspect of being able to connect and support those family caregivers.
Well, we've just got a couple of minutes left. I'm going to try and put a wrap on this. So much of what we've talked about this afternoon falls under the public policy umbrella in one way or another, whether we're talking about payment systems, who pays and how, whether we're talking about the workforce crisis. It's been a crisis and it's become more of a crisis. Quality of care and quality of life, family caregiver support, how we can help provide incentives for people to take these responsibilities on, and other things that we've talked about. So much of this just requires legislative support, both at the state level and at the federal level. So I hope if nothing else that comes out of this session, I hope there's a greater realization on the part of the audience and a part of others who will hear about this session or what the Gazette might do to cover it. A growing awareness that action is just necessary. We've talked about these things for a long, long time, and it's no longer, I think, a good time to just continue to talk about them. I think we really need to have action, and I think that's going to take collaboration amongst all of us and many more to get the kind of system that we'd like to have that supports residents, that supports workers, that support providers, that support communities, meets people's needs, allows people to lead better lives. All of you folks are involved in this work. God bless you for what you're doing. Let's just agree to continue the conversations that lead to action. So with that, I want to thank each and every one of you. I want to thank the Gazette. I want to thank members of the audience. And let's keep working on these issues so that we can get where we want to get to for the people that really matter most. That's the people we love and the people in our communities, our friends and neighbors. So thanks to all of you for being part of this afternoon. and we'll close this thing down.